Hello everyone, I'm Dr. Rita Roy, CEO of the National Spine Health Foundation. Welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me on the panel today. I'm delighted to be joined by Dr. Paul Anderson and Dr. Venu Nemani. I'm going to turn the program over to Dr. Anderson, who will introduce himself, and then Dr. Nemani will introduce himself, and we're going to talk about a fascinating topic of neck conditions and bone health. Dr. Anderson?
Yes, welcome everyone. I'm Paul Anderson. I'm an orthopedic spine surgeon at the University of Wisconsin. We are today being interviewed at the Cervical Spine Research Society annual meeting in Chicago, and thus the topic will be bone health and cervical spine disease.
Thank you. Dr. Nemani?
I'm Dr. Venu Nemani. I'm an orthopedic spine surgeon at Virginia Mason Medical Center in Seattle, Washington. And as Dr. Anderson stated, the Cervical Spine Research Society is a gathering of the world's experts in cervical spine surgery, where we discuss the newest research and clinical techniques on how to improve the outcomes of patients with all sorts of cervical conditions, including those with both surgical and non-surgical conditions.
Thank you, Dr. Anderson and Dr. Nemani, for those great introductions. The Cervical Spine Research Society is an important coalition partner alongside the National Spine Health Foundation, where we work together to bring expert insight to you to help inform patients and the public about neck conditions and what to do when one arises. Today, we're going to talk specifically about how bone health affects problems in your neck. And so, Dr. Anderson, talk with us a little bit about a condition called osteoporosis and how that affects the neck.
Osteoporosis is bone fragility. That means the bone is much more likely to fracture. And this is a very common disease that we see throughout the world. And in spine surgery patients over the age of 50, about 30% of patients will have osteoporosis. The good news is that if it's diagnosed and properly assessed, there are effective treatment strategies. At the intersection of cervical spine disease and osteoporosis is really important to understand, because the outcomes of surgery are much poorer in patients with untreated osteoporosis. Therefore, if you're over the age of 50 and are undergoing cervical spine surgery, it's really worth considering, how is my bone doing and do I have osteoporosis?
Yeah, thank you for that, Dr. Anderson. I think that's so fascinating to think about the importance of bone health if you're going to have a surgery in your neck, if you need to have a surgery in your neck. Dr. Nemani, sometimes patients don't need to have a surgery in their neck, but they still need to worry about their bone health. Can you talk to us a little bit about what that picture looks like?
As Dr. Anderson said, a large percentage of the population has osteoporosis, and it's one of these silent diseases, right? That you don't really know that you have it until you present with a fracture in many cases, unless you've been properly evaluated. But even if we ignore spine disease for a second, people with osteoporosis are at risk for hip fractures, wrist fractures, shoulder fractures, all sorts of fragility fractures, in addition to spine fractures, right? And so it's very important to have this evaluation done and to know if you are someone who has this condition.
Yeah. And Dr. Anderson, we know that many patients who suffer with a neck condition do not actually need surgery to correct their condition. But for those patients who do need surgical intervention, it's very important to check that bone health, because you're going to be putting metal, you're going to be putting screws and instruments and things into that bone. Talk to us about what happens if we don't check that bone health before surgery happens.
Yeah. When you look at the osteoporosis and results of cervical spine surgery, you will see that in large studies with many hundreds of patients, you'll see a decrease in good outcomes, because the bone grafts that are placed in will fracture, they may not heal, or if metal or plastic cages are put in, Then they wear their way into bone, a condition we call subsidence. Also, hardware may fail, and this leads to poor healing, what we call non-unions, revision surgery, and other bone-related complications. In addition, you have to worry about having other osteoporotic-related fractures regardless of your cervical spine condition, such as a hip or other spine fracture or wrist fracture. And we would also like to treat and prevent those if at all possible. And this is a good time, since you're undergoing a bone procedure, to at least consider having your bone assessed.
How do fractures that occur in your spine affect your neck?
Fractures can occur anywhere in the spine, and the most common types of fractures that people often hear about that result from low energy injuries, so these are just the fall from bed or fall from standing, or what are known as compression fractures. And there are other types of fractures that occur as well, but these are the most common fractures that present in the spine. And although compression fractures are not very common in the cervical spine, they are very common in the lumbar spine and the thoracic spine. What can happen with these compression fractures is that this can progressively result in a loss of alignment. And so this is where you'll commonly see older women or men who are very pitched forward. And that can be from several different causes, but one of the causes is from multiple compression fractures. Now, if a lot of those fractures do result in being pitched forward, that can sometimes, and especially if that's in the upper part of the back, that can result in difficulty holding your head up, a condition known as a chin-on-chest deformity. And this is something that can affect people's ability to look forward and to see the world. It can secondarily then result in an increased risk of falls. It can even, in very, very severe cases, affect someone's ability to swallow and to maintain nutrition. And so it really can be a very, very disabling condition that is often linked to very poor bone health.
And so when you talk about pitching forward, can you explain exactly what you mean by pitching forward?
So normally humans are able to stand upright without having to use very much energy. And so our spine has some natural curvatures in it, and that allows us to stand with our head over our pelvis, whether you look at someone from the front or look at someone from the side. But if you look at someone from the side and their head is very far forward in front of their hips or their feet,
they're leaning
forward. That is a very uncomfortable position for someone to stand in. It requires a lot of muscular energy. And you can imagine if your head is very forward from your torso, the head is like a bowling ball, right? And so if you hold a bowling ball out far from you, you can't do that very long until you get tired. Whereas if you're holding a bowling ball really close to your body, you can hold it for a much longer length of time. And so in the same manner, if someone has a spinal malalignment or deformity, they develop pain and fatigue much sooner because of that increased need to use their muscles.
That's an amazing discussion, because we talk about the aging process, and the aging process is inevitable, but there are some things we can do to control what happens to us as we age, and bone health is one of those really important things that we can work on. There are treatments to prevent some of these conditions from happening. Dr. Anderson, you and I have talked about the role of balance as we move through time, as we age. And Dr. Nemani has just been talking about those curves of the spine that keep you centered and your body in alignment, and that can be impacted as we age so that we're not in alignment and maybe we're going to lose our balance. What happens in that situation?
Yeah, so people with spinal deformities, particularly the type that Dr. Nemani was mentioning, where you're pitched forward, you have a significant increase in risk of falls. And of course, if you fall and you have osteoporosis, likelihood is at some point you are going to have a harmful fall, and including fractures, but you could even have a traumatic brain injury, bleeding if you happen to be on anticoagulation in the brain as well, or even a spinal cord injury. And particularly when your head is jutted forward, when you fall, you're going to tend to hit your face. And that's where, in the cervical spine, we're seeing an epidemic of C2 fractures. And part of it is because people have these deformities and they fall and they hit their face or forehead first, and that causes hyperextension of their spine and may break in the upper cervical spine, particularly in the second cervical vertebrae. Another thing that this alignment issue can be associated with is to compensate for having your chin and neck bent forward, you tend to hyperextend or rotate your head backwards. And that's very good if you're 18 years old where you're nice and supple. But as you get older, those joints in the back of your neck do not tolerate that. And that can lead to arthritic pain from those joints. And so people who are constantly trying to pull their head back not only have problems related to muscle fatigability, but they also have joint-related pain from the arthritis, or sometimes the hyperextension can result in pinching of nerves, which also can increase your pain and even arm or symptoms.
So maintaining that good alignment, maintaining that posture helps prevent pain, discomfort, and subsequent problems that come with that. I think balance is something we talk a lot about in the aging process. We tend to lose balance as we age. So if our spinal alignment is off, then our likelihood of losing balance and therefore falls is higher. Dr. Anderson, you've done a lot of work in fall prevention and why that matters. Can you share with us some of your insight there?
Yeah. So first of all, falls are really common in preoperative orthopedic surgery patients. For instance, if you're going to have hip or knee replacements, about 1% of patients fall regularly in the year before they have that joint replacement. And interestingly, the same percent fall after surgery. In the cervical spine patient population, in the older patients, so these would be people over the 65, let's say, the risk of falling is even greater because many of the indications for surgery is due to compression of the spinal cord, which of course is going to affect the strength of your extremities, the sensation of your extremities, as well as coordination, which all lead to even a significantly more increased risk of falling in that population. And so it's one of the tips I would tell patients that if you've had a fall within 12 months, tell your spine surgeon about that, because that is something that should be discussed. Now, maybe it's related to the cervical spine disease you have, and that will hopefully go away when he or she operates on you. But there also may be an underlying treatment for it, such as fall prevention strategies with physical therapy that are needed either before surgery or after surgery.
Dr. Nemani, you mentioned a condition called chin-on-chest deformity. It's kind of surprising that that's actually a medical term. It doesn't sound like a medical term, but I think it is a medical term. And one of the things that I think you've studied a lot about and you see in your patients is the difficulty in treating that kind of condition. Can you share with us your insights on that and why prevention is so important?
Yeah, chin-on-chest deformity is an actual medical term, believe it or not, and it's aptly named because it describes exactly what the condition is, where someone's chin is stuck on their chest like this, and sometimes it's flexible, meaning it can move, sometimes it's very rigid, meaning someone's head is stuck that way. And it's, as I described, it's one of the most disabling conditions. It's up there with, fulminant heart failure and renal failure and things like that. And it's something that really does not have an effective treatment other than either you live with it or surgical intervention. However, the surgical interventions are fairly extensive that are needed to correct these deformities, and the patients that often have these malalignments often are very sick with other medical conditions as well, and so it makes the risk quite high. When you add osteoporosis on top of that, it further increases the risk of complications with surgery, because the way that we correct this malalignment is by using screws and rods and cages to essentially mechanically realign the spine and put it into a more biomechanically favorable position where the head is centered over the rest of the torso. Mm-hmm. However, if the bone is weak and not strong enough to be able to for us to be able to maintain screw fixation, then you can have, as Dr. Anderson mentioned previously, screws that pull out of the bone or fractures around the screws, mm-hmm. which may require more surgery or cause pain.
So again, anything we can do preventatively is going to be helpful. We want to prevent some of these conditions from happening, and bone health is a big driver into some of these conditions occurring in the natural aging process. So we have bone health considerations both from a prevention standpoint and also from a surgical optimization standpoint. We've talked a little bit about fracture prevention as well. Being in spinal alignment, keeping your balance is going to prevent you from having other fractures. Dr. Anderson, we've talked a little bit about some of these other fractures that can happen. What have you seen in your practice to be most effective in helping people with bone disease and helping them understand the importance of preventing fractures?
It needs to be a comprehensive, usually multidisciplinary care initiative to try to make this happen. The first thing is to identify yourself whether you have osteoporosis. The National Spine Health Foundation has a lot of information on their website, and I urge you to go to that, about how you can diagnose yourself or at least start the discussion of the diagnosis of osteoporosis. So I would urge everyone to take a look at the educational materials about that. But from my perspective as a spine surgeon, we need to screen patients for osteoporosis. And some of the tips that are easy to identify, if you have had a fracture after the age of 50 that was relatively low injury, low energy, such as a fall from height or fall out of bed, or even in the case of a spine, a lot of times it's just lifting a heavy object can cause spine fractures. That's a good indication that you likely have osteoporosis, and it's also a very strong predictor of bad outcomes from spine surgery. Another one is if you've had a parent with a history of a hip fracture, significantly increases your risk of fracture. There are a number of medications that are harmful to bones. The most common one that we see are people who are on sustained corticosteroids. The drug is often called prednisone. It's used for a variety of conditions, and that drug significantly causes osteoporosis and poor outcomes with spine surgery. And there are many other conditions. And also, there are specific criteria that primary care uses to determine if you should be screened for a bone density test, which is called DEXA, D-E-X-A. And this test will determine your bone mineral density, also calculate your future fracture risk. There's certain criteria that are used to determine that, but some rough ones are if you're a female over the age of 65, male over the age of 70, or if you've had a fragility fracture. Those are all good indications to have a DEXA screening before surgery. So that's the first step, is to be screened. There are other techniques that surgeons can use to also help us, but those are the simple ones that patients should be able to understand. Next is, what do you do if you are diagnosed with osteoporosis based on the DEXA test, as well as other things that are related to your history? Well, then you need to be referred to a bone health specialist or the surgeon. Also, some surgeons are able to do this themselves, but more typically, you're referred to a bone health center, and that can be a medical doctor such as endocrinology, rheumatology, or more commonly today is fracture liaison service, which is a multidisciplinary team which takes care of further assessment of your bone health. And then there are medications that can reverse this and mitigate the surgical risks that we're talking about. Another possibility is to go through your primary care doctor, but oftentimes we found that is not always that effective. Primary care doctors aren't used to prescribing many of the more potent medications that we use for this, and so oftentimes the treatment there, particularly in the preoperative patient, is not optimal.
Thank you for that, Dr. Anderson. Very comprehensive overview of how to find out if you have osteoporosis and what to do about that and who to see for that. I'd like to ask Dr. Nemani to share with us some of the good news in osteoporosis care. There's been some confusion and hesitancy amongst patients to actually get treated for their osteoporosis. You both have shared with us today how important managing and treating osteoporosis is for preventing the progression of neck conditions and also for optimizing for surgical intervention. And so what good news can we share with patients about modern treatments that are available that can help them if they are told that they have osteoporosis?
Yeah, well, I think now we really have some good medications that are available to treat this condition, and we understand it better than we ever have, obviously due to research that's been done. Mm-hmm. And the benefit of identifying this early through the screening processes that Dr. Anderson identified or stated is that it can be treated before someone has a fracture, or also before you develop a surgical condition that might need to be dealt with on an urgent fashion. Again, many of the cervical spine conditions that we take care of, we're treating neurological problems.
Yeah.
And oftentimes there is not the time that we can take for optimization where we treat someone for 3 to 6 months prior to surgery.
Yeah.
And so early identification and treatment so that if you were to develop a problem, then your bone has already been treated.
Yeah.
There are 3 now medications that are bone building medications, in addition to many medications that are medicines that stop or slow bone destruction. Mm-hmm. And it depends on your unique circumstances which type of medication is best, especially in the cases of where patients have spinal deformities. Mm-hmm. And they have osteoporosis or need an extensive surgical reconstruction. Often the bone building medications are the ones that have been associated with better outcomes, better resolution of low bone density and bone quality, and these medicines are very highly effective at decreasing not only complications from spine surgery, but also risk of other spine fractures or other fragility fractures of the hip or wrist.
Yeah, that's exciting, and I thank you for sharing that with us. I think Dr. Anderson mentioned, and you have mentioned, Dr. Nemani, there's a lot of information that we've created at spinehealth.org to help you understand the different medications that are available, the different treatment therapies, how you can determine whether or not you have osteoporosis, and we've shared today, particularly focused on neck conditions, why it's so important and why it matters to get your bone health treated for your overall health and your long-term health. And there are so many other things that can happen to your body when you don't know what your bone health quality is. I think it is really important for patients to understand that bone is a living organic tissue. I think sometimes people think that your bones are like a glass of water. It's just there, and it serves, it's got a vessel function, and that's true for your spine. It is the vessel for your spinal cord, but bone changes, and it's an organic living tissue in your body, and so taking the medications that can help build up your bone or slow down the loss of bone, that careful balance that your doctor will work through with you is really important to your current health and your future health. Dr. Anderson, do people need to delay surgery if they need it to get their bone treated first?
Yeah. In many cases, yes, a delay would allow us to improve bone strength and prevent these complications we are talking about. However, the delay has to be balanced against the needs of the patient. If there is an urgent neurologic reason to undergo surgery, then I would advocate getting that dealt with and then treating the bone after surgery. However, more typically, if we can wait, if the patient can wait based on their symptoms, then it is much better to wait about 3 months to be treated with these bone building drugs. By then, we'll see a significant improvement in bone mineral density as well as bone strength and also bone biology. So this is a typical time. Dr. Nemani has described these bigger operations for people with bad deformities, which may involve 10 levels of fusion and very extensive procedures. It looks like those patients benefit from even longer periods of delay. For instance, somebody with a chin-on-chest type of deformity, but the problem is in the upper back, then that patient might be better treated up to 6 months. One of our colleagues on the foundation did a nice investigation and showed that 6 months of treatment resulted in osteoporotic patients having the same complication rates as normal patients. So in other words, you took a osteoporotic patient who had a significantly higher rate of complications, theoretically, moved them back to normal with 6 months of treatment before surgery.
That's exciting.
So the delay in surgery will have to be balanced against the patient's needs and how long one can really wait for surgery. But just if you're a patient, you need to understand some patience here, that if you're diagnosed with osteoporosis, the surgeon is not trying to punish you to recommend a delay in surgery. He's trying to do what's in your best interest.
Yeah. And speaking of those surgeries for the neck, Dr. Nemani, if patients have poor bone quality or osteoporosis, they may not be able to have certain necessary procedures. Can you talk to us about that?
Essentially all the procedures that we do that require spinal instrumentation require the bone to be strong and to support the implants that we put in. Some of the newer treatments that we have now in the cervical spine, certain patients and certain problems can be treated with cervical disc replacement rather than cervical fusion, which is nice because it maintains motion at the index segment, which can be very beneficial in the properly selected patient. Osteoporosis, unfortunately, presents a contraindication to actually undergoing a cervical disc replacement because those devices in the setting of poor bone can actually subside or fall into the bone and create a fracture.
They get sucked into the bone, they go into it.
And then that can cause a big problem that then might require a bigger operation to fix, often then resulting in conversion to a fusion and a bigger surgery than was initially necessary. And so again, having your bone optimized and having the normal screening tests when your primary care doctor recommends them is important, so that if you do need an operation for any sort of urgent issue and you don't have time to wait, you might be then a candidate for some of these newer types of treatments if your bone quality is good.
Yeah, that's you bring up the interesting point about motion in the neck. You know, a chin on chest condition, your neck is sort of stuck in that position, and our necks, our spines are meant to move. So preserving that motion is so important. It's neat that there are new surgical techniques to allow for motion sparing for the right patient, for the right reason. But if osteoporosis is there, they may not be able to have that kind of procedure. So yet another reason to get the osteoporosis, the bone health, checked and treated. Should we close with closing pearls?
Yeah, sure.
Okay. This has been a really important and fascinating conversation about the cervical spine and bone health. And we are going to close now by asking Dr. Anderson and Dr. Nemani to give us some closing pearls of wisdom.
If your patient is considering cervical spine surgery over the age of 50, it's worthwhile asking your surgeon, do I have osteoporosis, and do you meet any of the screening criteria that we talked about or that is available on some of the patient information on the National Spine Health Foundation website and see if you need further testing, such as the bone density test, or what we call a DEXA scan. And if that DEXA scan shows you have osteoporosis, then you should have a discussion about the timing of surgery versus whether you need to be treated with some of the more effective medications.
Dr. Anderson, thank you for encouraging patients to ask for these things from their providers. I think that's so important that we encourage people to remember that they are their own best advocate, and that is a great place to be. Sometimes patients are reluctant to ask their doctors for things because they think they might be being rude or disrespectful or uninformed, but we encourage people to think about their bone health and talk to their doctors about that. And thank you for that encouragement. That's really wonderful. Dr. Nemani, closing pearls of wisdom for our audience.
My pearl is for those patients who are not yet needing to undergo cervical spine surgery, to make sure you get appropriate screening and testing for your bone density so that you don't become a patient that needs surgery and can't have it because your bone density is too poor, or that you become a patient who develops a significant cervical deformity or malalignment because of fractures that occur in the spine. And so the best treatment is prevention, and so it's important to get your bones checked.
That's fantastic. We are so grateful to these experts for joining us today and sharing these insights about keeping your body in motion. Your overall general health is dependent on your spine health. Your spine health is dependent on your overall health status. That includes knowing your bone health. I want to thank these surgeons who put the best of medicine into practice every day for their patients and have joined us today to share their knowledge with all of you. Thank you very much for joining us.